Knock, knock, knock. We're going to come in the room, and this is going to be a presentation of assessing the infant. First thing we're going to do after gaining access to the room is we're going to identify the infant. We're going to do that by correlating both the infant's brace with the mother's brace, making sure that they have the correct first and last name, the correct medical record number, and date of birth if we need to refer to that. After that, after we've made sure that we're in the right room with the right infant, the right patients, we will go ahead and discuss thermoregulation and assess the infant for thermoregulation. Infants lack the ability to shiver if they're cold. Increased storage of brown fat stores help them to regulate their body temperature. We want to make sure that the infant is swaddled with a cap on its head where it usually loses most of its temperature out through the head, so we want to make sure they're nice and covered and bundled up. It can lose heat through evaporation, conduction, radiation, and convection. So again, we just want to make sure that we do everything we can to help the infant maintain a normal temperature, which should be 97 to 99.5. So we'll go ahead and make sure he's comfortable and he's not either hypo or hyperthermic. Prior to moving forward, we're going to make sure we have all of our equipment, everything we need to complete this assessment, and then we're going to make sure that all of our equipment is cleaned, and anything that needs to be sterile is sterile. We have our scale, we have our stethoscope, our pen light, and any other necessary equipment. Of course, I'm going to make sure that I use hand hygiene and I clean my hands. We're going to use personal protective equipment throughout this entire assessment. I also want to make sure I use proper body mechanics and that I ensure the safety of my own body and the patient, and that we maintain privacy throughout this entire process. So after coming in and doing our initial part, I will then go ahead and start to gain some subjective information. We'll do that by asking the mother. The infant obviously can't communicate with us verbally and has little background information to give, so we're going to pertain all the information to the infant according to how the pregnancy went and how the birth actually went. We'll ask the mother things like whether she had a normal pregnancy or whether she had any complications, whether or not it was preterm or whether the infant was post-term baby, whether they were the infant was underweight or overweight. We want to make sure that we assess whether we want to ask the mom whether the infant had a cesarean section or whether it was a vaginal birth, any hemorrhaging, whether the infant was whether the infant required the use of forceps or a vacuum. We want to ask the mother how she is maintaining the nutrition status of the infant, whether the infant is breastfeeding or by formula, and whether she understands how to correctly measure the intake. And then we will go ahead and move into, after gaining all necessary subjective information, we will go ahead and move into gaining objective information. We're first going to just perform a general assessment of the infant. We're going to come in, just look at the baby, make sure that he's not in any apparent distress. Before we go into our actual assessment, we will do our vital signs. We will look for any acrocyanosis. We'll uncover the infant, not undress them, but unswaddle them, make sure that their skin tone looks okay. And before we get the infant really riled up, we're going to go into vital signs. And we'll start this by assessing the infant's respiratory rate by listening for a full minute. We'll do breath sounds at that point in time too. And we're also going to listen for a full minute for our apical pulse rate. And so we'll go ahead and assess. We'll make sure that this is nice and warm before we place it on the infant. And again, all of our equipment is sterile and clean. So we'll assess for 1 minute, getting a respiratory rate which should be anywhere between 30 and 60. And we'll also assess an apical pulse, right side of the chest, listening for any murmurs or abnormal heart sounds. And we're going to listen for a full minute for the apical pulse. Should be around 110 to 160. Unless there's an indication, we will normally don't do blood pressure. But if we did, we would go ahead and perform that as well. At this point in time, we would, after assessing apical pulse and breath sounds and respiratory rate, we're going to assess the temperature of the infant. We'll do that axillary. We're going to do this last because it will most likely be uncomfortable for the infant. We'll get a temperature of the infant, and then we will go ahead and weigh the baby. We'll make sure our scale is cleaned, warmed. If not, we'll have a blanket. Place the baby in the scale. Make sure that we're maintaining the safety of the infant while we weigh them. After we're done, we'll bring them back over. We're going to measure. We want to measure the infant in length, starting from the head all the way down to the feet. We also want to measure the circumference of the infant's head, and then we want to also measure the circumference of the infant's chest, noting that the head will be a slightly larger circumference than the infant's chest. After that, we will actually go into assessing our infant. We will start at the head, noting any deformities, any bruising, any swelling. We want to notice the skin color, condition. We want to palpate for any deformities. We want to look for any lacerations, signs of abuse, or anything like that. We want to assess the suture lines, make sure that they're in the appropriate spot. We want to assess the posterior and anterior fontanelles for either them being sunken or swollen, indicating if they're sunken, dehydration, or if they're swollen, increased intracranial pressure. The posterior fontanelle should be closed by 3 months, and the anterior fontanelle takes 9 to 18 months. We'll move down from after assessing the head to the eye area, noticing, taking a look at the pupil, the sclera, the eyelashes, the conjunctiva. We want to make sure that the conjunctiva is pink and moist. We don't have any drainage. We want to notice the symmetry of the eyes. I will also take this time to assess the infant's pupillary response, making sure they're equal and reactive to light. I will wave my hand over the baby's face, watching for him or her to follow my hand, testing the infant's ability to move their eyes accordingly. At this time, I'll look to the side of the head and assess the ears for any drainage. I will make sure the ears have nice flexibility, and I will also make sure that they are not low set. I will check to see if they line up, the top of the ears line up with the outer canthus of the eyes. Indication of low set ears could be any chromosomal abnormalities. I'll then look to the nose, assess for patent nares. I'll look for any nasal flaring at this point in time, whether the infant's having trouble breathing. I want to look at the bridge of the nose, checking to see if it's normal or if it's flat, which could also indicate a chromosomal abnormality. There might be milia located on the nose at this point in time as well, which is normal and goes away soon after pregnancy. Then we'll go down to the mouth. We're going to assess the oral mucosa, making sure it's moist, pink, no swelling or drainage. Any bleeding might be Epstein pearls on the gums, which is another normal indication, and usually subsides soon after pregnancy as well. I'll look for a tongue, whether it's swollen or not. At this point, I will take my small gloved finger and stick it into the mouth of the infant and assess for a suckling reflex. While my finger is in there, I will assess the palate, making sure that's present and intact in the rest of the mouth. I will also at this point gently stroke the infant's cheek, assessing for a rooting reflex. The infant should turn towards whichever side of the cheek I'm stroking. We'll go down to the neck at this point, which is almost non-existent in the infant, noticing the trachea, making sure it's midline. Moving into the upper chest, I want to look at the clavicles at this point and assess whether or not there's any swelling or deformities, any indications that the shoulders are dislocated. Again, skin, temperature, color, condition. I will grab the arms and make sure that there's a proper range of motion and that I don't feel any crepitus. I'm looking at the chest for any for the symmetry, shape. I'll palpate the clavicles as well and make sure that they are intact. I will bilaterally check for brachial pulse. I'll go down. I will perform a palmar reflex or grasp reflex, and the infant at this time, if I put my finger in their hand, should grasp firmly. I'll assess for cap refill, and again, just palpating their arms, making sure there's no crepitus or any signs of contusions, any bruising. I'll assess the infant's breasts, make sure that the nipples are intact and there's no abnormalities. While I'm here, I'll perform the Morrow reflex, which I'll just gently lift the infant's back off the bed, and the infant, when dropped, should startle. Then I'll move down to the abdomen, and again, I'm just going to look before I do anything, noticing any the contour, the shape of the abdomen, any pulsations, visual pulsations, or swollen masses that I can see. I want to pay particular attention to the umbilicus at this point. Depending on how long ago the baby was born, I want to look at the umbilical cord, make sure that that's healing properly, any signs of infection. It should be hard on the distal end of the clamp, similar to a nail of someone. So that should be healing well. I will assess the infant's abdominal sounds, noting for any abnormalities. Again, starting in the lower left-hand quadrant, working my way around clockwise, listening for the absence of bowel sounds. At this point, I'll expose the diaper, and I will see if the infant has defecated or voided, which will give me a clue as to maybe if he has active or hyperactive bowel sounds. See how his GI system is working. I will notice the infant's genitalia, whether he is male or female. If it's female, then the female might be swollen in her genitalia area, which is normal because of maternal hormones. There might be a little bit of drainage as well from the vagina, which is also normal. If it's a male, I want to make sure that both testes are present and they have dropped. The presence of any rugae. I want to make sure there's no drainage or swelling coming out of the penis. Everything's intact there. At this point, I will move to the lower half and grab the infant's legs, and I will perform the Barlow and Ortolani test maneuvers, and I will, at a 90-degree angle, rotate the legs, feeling for any crepitus or clicks, indicating hip dysplasia or dislocation, and also testing for range of motion. I'll continue down the legs, palpate, assessing for any abnormalities, noticing the skin, looking for any bruising or swelling, any acronosis in the extremities down to the feet. I will check for distal pulses, also for moral pulses. I will perform also at this point in time the Babinski with my finger reflex. I perform this by putting my finger up the infant's foot, and the feet should fan out, or the toes should fan out on the feet. After we're done with the front of the infant, we will gently turn the infant over, and we will assess the posterior part of the infant's body. We'll test the Gallant's reflex, gently stroking either side of the back, and the infant should flare out towards that side, whatever side I'm stroking. We want to look at the spine, assessing for symmetry and making sure that it's midline, no deviations or anything abnormal with the spine. We want to look for the presence of any thing that would indicate that we have spinal cord abnormalities, any hair growth down towards the sacrum, any Mongolian spots that we see, any raised areas. I also want to check the posterior of the head, the skin, color, temperature, condition. I also want to inspect the anus at this point. Whether or not the infant had defecated will give us a clue as to whether he or she has a patent anus. I want to look at the gluteal folds, making sure that they are consistently come across at the same point. If not, one is uneven, then it could indicate signs of dislocation or hip dysplasia as well. And after we're done, we will swaddle the infant back up, and that is it.